All right, well, let's get started. Are you seeing the Prezi screen now? Good. All right. All right. Well, first, we're going to talk about the research that I've been doing around advanced care planning. And we've been doing this work. I came here in 2013, and I've been doing this work for quite some time. And I'm going to take you through sort of a timeline of how we got started, what the issues are in our field, and sort of how we went from pilot studies all the way to our NIH project that is now in its fifth and final year. So this talk is called Implementing a Nationally Scaled Randomized Controlled Trial about Advanced Care Planning in 75 Underserved Communities, Lesson Learned from Project Talk Trial. And just did my introduction. Thank you. I have no conflicts of interest other than I'm an unpaid scientific advisor for Common Practice LLC, which is the company that makes the game and sells the game that I am presenting my research on. And you can see my research support for the work that I'll be discussing today. All right, so diving in first, for those of you who aren't familiar with advanced care planning is a very important process because patients who are often critically ill lose capacity and are not able to make decisions on their own. And that can happen in up to 70% of patients who are admitted to the intensive care unit, which is an area where I practice. But also, as patients get older and have various illnesses, they often will need to rely on surrogate decision makers. And those surrogate decision makers often have to make difficult choices, whether they're end of life decisions or treatment decisions, caregiving decisions. It's an extremely stressful job to be a surrogate decision maker, so much so that 50% of patients who have to make decisions for someone else experience overt anxiety, depression, even 13% can experience overt symptoms of PTSD. And those psychological morbidities are longstanding and they can go on for up to a year or more after a decision needs to be made. And so this is the problem that we are trying to address in our research. Sorry for the things. I don't know why they're having trouble with the thing. Okay. So the solution to this problem is advanced care planning. And what advanced care planning is it's a process where patients think about what they would want at end of life, or if they weren't able to make choices for themselves, they think about the issues, their preferences, their beliefs, their goals, and then talk about them with their loved ones, their family, their clinicians, and then subsequently can document changes in an advanced directive. And that's the process that we call advanced care planning. We know advanced care planning can help some of the problems that I talked about already with anxiety, depression, and PTSD. Patients who have gone through advanced care planning are less likely, their caregivers and themselves are less likely to have these issues. And for the health system, advanced care planning can help reduce end-of-life care costs, which are often exorbitant. Most of the healthcare costs for an individual and for society are spent in the last 6 months of life on treatments that are often questionably beneficial. And so advanced care planning can help reduce healthcare costs by up to 36%. But perhaps most importantly is advanced care planning helps people to make better decisions so that they're more likely to get care that's consistent with their values and preferences. But that can only happen if people have had conversations and have thought about what their values and preferences are. So unfortunately, in the US, only 25 to 60% of our population has engaged in some form of advanced care planning. Now, it's a pretty big range. In the 80s, before some federal legislation, it was closer to 25%, one in four. Nowadays, there was some legislation and some pushes to do advanced care planning, and that number has risen to 60%. But even so, in underrepresented communities like Black and Hispanic communities, the rates have remained low at less than 25%. So while we've made some headway in older populations, usually affluent white populations, we still have a lot of work to do in our Black and Hispanic communities. So why don't people do advanced care planning? Hoping that the sound and everything is still okay. Um, so barriers to advanced care planning, first of all, I think it's the obvious, right? Nobody wants to think about death and dying. It's not a fun topic. It's not something that's very necessarily an optimistic thing to think about. And there's a lot of reluctance and stigma around talking about these issues, particularly with family. Um, Other barriers include lack of opportunity or context. People often don't know where to start these conversations. They may not have the knowledge or know what they should talk about. They know they should talk, but talk about what? How do I start this conversation? There's differences in cultural norms. In some cultures, it's very taboo to talk about these issues. Some people don't feel empowered or confident. They don't know, they don't have an experience with which to ground these conversations. And then talking with clinicians is also a barrier because clinicians are very busy and these conversations can be very lengthy. And so resource limitations, clinician time during visits, they're, going through the 15 medications and all of the things that need to happen in a primary care visit. This often gets pushed to the bottom of the list if dealt with at all. And then finally, a lot of issues around distrust in healthcare, particularly in underrepresented communities. People don't want to talk about withholding or with not receiving potentially life-saving treatments, and they don't feel comfortable talking about limitations of care. So these are some of the barriers that our work is hoping to, or our work does address, I should say. So before I talk about our approach to advanced care planning, I'll just say that there's been a lot of interventions out in the literature that have not had great success or have had mixed findings. A lot of them are time intense. They require one-on-one interventions with social workers, nurses, clinicians. I already talked about the time barriers folks have. There have been interventions that have done like electronic medical record flags and prompts, and with AI, I suspect that will get renewed attention. A lot of education programs, conversation communication programs, online decision aids, and then posts are a whole separate topic that I'm not going to get into. But these are some of the interventions that have been done out in the world, and again, have had mixed findings as to whether they really create impact. Gosh, I don't know why it is doing this for me today. A lot of the research on this has showed, like I said, barriers that just aren't addressed related to the resources. The effect sizes of these interventions are small to moderate at best. And one of the big criticisms in the field of advanced care planning is that advanced directives are not very helpful in all situations, right? They are sort of black and white pieces of paper that say, I would want this, 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 but not this in this particular circumstance. And so they're not living, breathing, dynamic documents. And that's part of the problems with advanced directives. So we need new approaches to deal with this issue. So back in 2013, when I was just moving to Hershey, I just graduated my pulmonary and critical care fellowship. I got a phone call from a guy named Nick Jellin at a company called Common Practice. And he said, I've heard about some of your work. I was doing a little bit of research and I'd written a book about end of life issues. And he said, our company created this game and we were wondering if you'd want to do research on it. It's meant to help people talk about end of life issues. And I thought to myself, that's really a strange approach, right? A game to get people talking about end of life issues. I thought it was a little nuts, but as I started to think about games and looked into the field of gaming, I realized that there's a whole sort of world out there on games and health behavior. Not only are there increasing studies over the years, but there's a lot of rigorous work around behavior theory attached to these games. And there's a lot of enthusiasm and good findings out in the literature in a variety of fields about using games for health and for behavior change. So I sort of rethought it after I got here to Hershey, and I thought, all right, let me hear more about this game. So this is the game. It is called Hello, and it is a very simple intervention. It's played in groups of 4 to 6. And you can see it's a booklet and it's got chips and rules and all of those things, which I won't go into in exquisite detail. But what I love about the way that the company created this game was that they used a lot of scientific approaches to create the game and to order the intervention itself. So the game itself doesn't have a lot of rules. Like the main rule is to listen, and there's chips and there's sort of everyone goes around a circle. You open your question book, you look at the first question. It's an open-ended question. You read it, you write down your thoughts, and then you share it amongst the group. And then as people are answering the questions, if someone says something that's particularly poignant or thoughtful, you can extend a thank you chip, these little blue chips. And so people will give and take chips at their whim during the game. If someone says something really funny or maybe makes a joke or everyone has a chuckle, that they throw chips at the person, or maybe someone says something that's very vulnerable or shares something very deep and personal or tears up, someone might, give them a chip. They're kind of like empathy tokens in a way. So that I think is a really important part of the game, is that they have these chips and this open-ended sharing forum, which creates this environment of psychological safety. And the rules and the goals are all user generated. what I mean by that is when you open the book, the first question is that you answer in your group is, what are your fears about playing this game? And so people will write down, like, oh, I'm afraid that everyone's going to be crying, or I'm afraid that I'm going to say something stupid, or something like that. And so what that does is when people are sharing their fears, they're setting rules and expectations about what worries them, and letting people know, like, these are the bounds. Like, let's not get overly emotional here, or take what I say with a grain of salt. Be kind to me, because I'm worried about how you're going to think about me. And so those kinds of boundaries within the game environment are set by the user based on how they answer this question. They don't even know that they're setting the rules, but they really are when they answer question number one. Question number two is the goals question. What are your hopes about playing this game? And that sets the expectation of what they want to get out of the game. So if I'm playing with someone, I may say, I just want to have a good time. That's very different than if I say, oh, I want to learn what my husband's end of life wishes are. Right? Those two players are coming at it with a very different approach. And so by using this open-ended question, it allows the group to level set in a way about how this game is going and what the goals of the game are. The third question in the booklet is this one, and it's, if you've had, give yourself permission to do. And the purpose of that question is to sort of fire the flag, like saying, hey, we're going to talk about mortality. And so it brings up the topic. It grounds the group in the topic of mortality. If you had 3 months to live, what would you do? And people will often have fun with that question. Oh, I'd jump out a plane. I'd buy 100 lottery tickets and try to give the money to my kids, or whatever it is, write legacy letters. And so people tend to get into the mentality of thinking about death and dying in a way that's non-threatening. And then the fourth question is the most important question in the advanced care planning process, which is name the three-person committee who would make decisions for you if you're unable to do so yourself. So then people start naming their surrogates, and then the rest of the game kind of flows along after that. And it's paced with lighter questions and heavier questions. So some of the questions are very light and easy to answer, things like, what music do you want to be listening to on your last day alive? Or you could pick someone to sing at your memorial service. Who would it be, and what would they sing? So these are very sort of lighthearted, and people can come up with like playlists, and it's just sort of a non-threatening way to talk and think about mortality. And those are sort of peppered in with more heavy questions, like these here, in order to provide you with the best possible care, best care possible. What three non-medical facts should your doctor know about you? Or which is more frightening to imagine, suffering the worst pain of your life for not getting a chance to say goodbye to family? So very important questions. You can see they're getting at trade-offs, values, goals, beliefs, things that are important, things that matter most. But it does so in a way that allows people to do it in a non-threatening way. So my first research question was really just like, is anyone going to play this thing? Because I thought, who wants to play a game about death and dying? And that was to me the major question that I had. And this was the first grant that I ever applied for. It was a small SSRI grant. Um, in science, in translational science, we call these, feasibility studies and acceptability studies. So what we did is we started conducting some early studies, using the game to examine those constructs of feasibility and acceptability. And so we put together some games, just to kind of watch and observe and see what happens. Some of our early funding, like I say, came from SSRI and the CTSI. You can see people here. Uh-oh, my internet's unstable. I'll stop for a second. Am I back? Am I back?
You never left. You're good.
I never left. Okay, good. Sorry,
Yeah.
said my internet was unstable. Okay. And so we put games together, some with individuals. You can see the group in the center. And then we also went to some community centers. I think this is Country Meadows. You can see it's a Hershey population, not a lot of diversity there. And we just kind of observed. And what we did is we did some qualitative analysis and something called communication quality analysis of the conversations that were happening. So I wanted to know not just will people play the game, but will the conversations be any good? And some of our early work, we found that yes, people played the game. They answered questionnaires about satisfaction. They answered questionnaires about whether they thought playing a game was a appropriate way to have these conversations. And then we listened to the game conversations and did analyses to see if they were having substantive and meaningful conversations. And sure enough, they were. I'm going to skip the video part of it, just because I'm not going to go into CQA. But Some of the questions that we asked again was what did they think and what did they talk about it? And what you can see is over time, down here in the quantitative part of our assessments, we did a bunch of pilot studies in different populations. Um, Volunteers, 70 volunteers in Pennsylvania and Kentucky, and then we did patients and caregivers, and then we did a pilot, and then we looked at South Asian Indians. So we did a whole bunch of sort of small studies funded by internal grants to look to see if the scores were consistent across all of the different populations that we were interested in. And I was really exploring at that time for whom is this game most salient. And what was really exciting about the quantitative data was not only that, on a score from 1 to 7, everyone was giving it a pretty good score, fives and sixes basically. But most important to me was that look at the high rates of behaviors. So when we called them 3 to 6 months after they played the game on the phone and we said, hey, have you had a subsequent follow-up conversation with your loved one or your clinician, or did you complete an advanced directive? The answers were almost always yes. I mean, 78, 74, 93%. The South Asian Indians had the lowest rate of behaviors, but these are really, really high rates of behaviors. And what was fascinating about this is that we didn't provide them with any information. We just played the game. We didn't give them advanced directives. We didn't give them anything to take home with them. And even so, they were going and they were talking more. So while they weren't really doing behaviors or advanced directives with high rates, that wasn't surprising to us because we weren't giving them and we weren't telling them to do advanced directives. We were really just sort of doing a naturalistic experiment to see what happens. But qualitatively, when we did focus group evaluations, we found some really important things about why the game works, which is, of course, why we love qualitative. So, what we learned is that the game provided an effective forum for advanced care planning conversations. And we hear this, we've played this game now with, probably 3 to 5,000 people. And every time people say, it's just a really safe space for you to have these conversations. And it's an effective way to sort of set the stage for the conversation. So, this quote, I found that very refreshingly with the game, it was presented in a context that was quite non-threatening. It was something that, was kind of inviting enough that it drew you in being with the community. And others, this was also really surprising to me because the game is just a bunch of questions. We're not giving them any information. We're not teaching them anything. We're not giving them advanced directives. But they all left feeling that they gained new information and new perspectives. And that was from the dialogue that they were having with their community peers or the people that they played the game with. So this person says, I enjoyed the fact that you actually got to hear someone else's view on the past, on life expectancy, on what they felt was important in their life. The sharing, I think, helps others. So you don't think, oh, I'm the only one who's thinking like this. So there's a lot of, in all of the focus groups that we've done, I've actually stopped doing focus groups now because we're hearing the same thing over and over and over. And it's basically just saying, like, people saying, I learned so much. It was so great to hear what others had to say and think about this. And it helped reinforce some of my own ideas or taught them new ones. But most important when you think about behavior change and behavior theory is that people left the game feeling empowered and motivated to do more. And we were seeing that, of course, in the behavior rates from the follow-up phone calls. So this person said, I was aware of a lot of the things they talked about, but I'd never acted upon certain aspects of it. Thinking about tomorrow, something could unexpectedly happen. So it prompted me to try to act sooner on it. So people were feeling empowered and motivated by what they were learning in the game. And so this was the result of a bunch of our early studies that really gave me the motivation and the pilot data to continue the work and to take the next step, which was to try to increase the reach and to get the intervention into populations that needed it most, which is underserved communities. So I'm going to dive into the next bullet. I'll stop for a second to see if anyone has any questions so far. Okay, I will just keep going. So we knew the game worked. We knew the game had a lot of good things about it, that it was motivating people, but we wanted to be able to get into underrepresented communities in particular. And for this, we received a medium-sized grant from the John and Wanna Harmon Foundation and partnered with the Hospice Foundation of America, who has been our national community partners, to develop what we now call the community-based delivery model. And how this works is that we, the project team, so it's Penn State, my team, our partners with at HFA, researchers, infrastructure type, folks, we solicit host applications. So a host is someone who's out in the community. Maybe it's a director at a senior center. Maybe it's someone who works for a hospice agency. Maybe it's a pastor or a church leader or a community member who's just really like excited to get these topics out into the world. Anyone can really be a host. But what we do is we really leverage the networks and the community trust that hosts have, particularly in underserved communities. If I go into a Hispanic community and I'm a redhead that only speaks English, and I go into a Spanish-speaking community, I'm not going to be very effective. Our host is sort of our bridge into these communities, the conduit, which they help us to take the tools and the infrastructure that we've built and deliver them in a way that the community members are going to be more receptive to. So what the host will do is they will sign up to work with us. And they will arrange a venue. Usually they're churches, sometimes libraries or senior centers, community spaces. And then they will invite their constituents to the event. So we actually don't do any recruitment, which is lovely because recruitment, as we all know, in translational science is really hard. And our hosts do all that hard work for us. So once they get their community center, their venue, they take care of all of the logistics. They invite folks. We give them money, stipends to provide meals and do any marketing that they may need. And then the hosts are really trained using our materials to run these events themselves so that when we come to the event, we're really there as a support system. We do the informed consent and the research procedures, the questionnaires and stuff we need to do for our data. But as far as like running the aspects of the event, our hosts are the ones that really are delivering the intervention, which allows us to be more scalable. So in the Harmon project, and this was published, I can't remember now, my gosh, 2018 maybe, 17, in JAMA Internal Medicine. This was our pilot study, and you can see it was a national pilot. We had 53 hosts. Of those 53 hosts, we sent the actual research team to travel to 15 of the sites because we were interested to know, do we need to be there or can we have the hosts really, running it without us? Like, how much touch do we need to be there? And the 15 sites that we chose were focused on African American or Black communities. And you can see that we sort of had a great distribution of rural, urban, across the US for our pilot research. And we called all of these participants 3 to 6 months after to learn more about what behaviors they did. So how the events would go is we would show up, we would do some baseline surveys. There's a measure called the ACP engagement survey, which helps us to identify how long or how ready someone is on the stages of change, conceptual model, the Prochaska's model, sometimes called the trans-theoretical model, whether what phase of readiness are they at for ACP engagement. Then they play the game for 45 minutes. Oftentimes we have to cut them off because they want to keep talking and talking and talking because they have so much fun playing the game. And then we would do our post game questionnaires, just did you like it? Was it acceptable? And this was extremely important in this study because it was our first time being in Black and Hispanic communities, and we wanted to make sure that there weren't any cultural adaptations that were necessary. And then finally, we called them 3 months later to recollect the data on the ACP engagement survey and ask a behavior list about whether or not they did advanced directives or talked with other folks. So just showing here, these are some events. So this is rural New York in Sodus. You can see a very rural area, very small church. We were in Tuscaloosa in Alabama. And you can see just sort of what these gatherings look like from these various communities. This one was in Las Vegas. I took the liberty of going to that one as well for it was a great time, not just for the game, but just learning about the communities and being out there with the people was just a really great trip. We were in Milwaukee, and again, you can see just people are really engaged. They're playing the game. There's a lot of smiles, that sort of thing. But most important, is
Yeah,
there a
I
question?
have to alarm the house.
Say what?
Fireball.
I'm
I
not sure if
muted,
that's a
I muted
question or
her.
someone heard a mute. Okay, got it.
I muted
Okay.
her. Yeah.
Okay. All right. So what was really great about this study is that we learned so much. First of all, we learned that when we traveled to the event to present the research, 90% of the individuals said yes to being part of the research study. However, when we asked the hosts, hey, would you hand out these questionnaires and ask people to complete them, only 48% of the people said yes to completing those questionnaires. So our presence at the event was extremely important. And 90% consent rate, and these were all Black communities, as you know, or as you may know, that Black Americans or Black individuals are less likely to want to participate in research. And we were getting 90% of them saying yes, which was really amazing. And we credit that to our host model where, our hosts were really standing side by side, shoulder to shoulder with us, showing that, we could be trusted and that they were involved in this and that they had reviewed all the materials and that it was okay to participate. And then we saw super high rates of behaviors. 98% of the 219 people that we called after the event, 98% of them had done at least one behavior and 67% three or more. 41% completed an advanced directive, which if you remember from the historical data, 25% is the baseline in this population. And so you can see the high rates of behaviors. This was a single-armed trial, so of course there's no control arm, but it was extremely exciting. And this was the real, I think, thing that got us the NIH grant for Project Talk, which was then the definitive randomized control trial of the intervention. So I'll just segue into this to say this big black circle here in the middle was 2019, I think we're in now. I'd been at it for 6 years, and it took me 5 submissions to get to my first R1. So for those of you that are out there working on grants, keep going, keep doing it. I think I somewhere on my timeline I started submitting here, wasn't getting I was getting good scores but not getting through, and then it was really after this study where we developed the community-based delivery model that we were really able to overcome some of the barriers in the reviews, and that got us through NIH onto the other side of the big divide. So that leads us into the project trial. Just want to look to see if any of my team members are here. I saw Dr. Van Dyke, Heather Costigan, Morgan Boucher, Kate Ferguson, Sama Ahmed, lots of people. I don't see any of them here, but I have a big thank you slide at the end. But I just want to say that all of these individuals have been really pivotal to this work because it is an enormous trial. And so this is a 3-armed cluster randomized control trial, and there's 75 host sites. So we had 75 sites across the US. Our goal was 1,500 participants, and it was a 3-armed trial. So we were comparing the Hello game to a control, which is the table topics game, which I'll explain in a moment. But we also had a second advanced care planning intervention, which was called the Conversation Project, which is an intervention that does very similar community venues and small group conversations, but it doesn't have that gamification, that gamified event. So that's what makes that intervention really a good comparator arm. The Conversation Project is an 11-page workbook. It's free to the public. You can just download it. It's got some slides and didactics, and then like a sort of script for leading groups through practice conversations. And this intervention doesn't have any research data behind it, but is nationally disseminated and is probably one of the largest community-based interventions out there, despite it not really having any data. So our project was really exciting because even if the Hello game wasn't going to work out or wasn't better than control, we would also be comparing the Conversation Project to control, and then we could compare the Conversation Project to the Hello game. So that was sort of like a win-win-win. No matter what intervention wins, you're going to have exciting data, and that's a good grant tip. All right, and so the control arm, Table Topics, is a game similar to the Hello game, except instead of it being about advanced care planning and end-of-life decision making, the questions are really like icebreaker questions. What do you love about your hometown? Sort of conversation starters. And we gave everyone at all the events health questionnaires and advanced care planning handouts so that everybody at least got information about advanced care planning. They all got advanced directives and a little, brief spiel about why advanced care planning is important. And the experiment was to see which of the priming interventions, the Hello game or the Conversation Project, would stimulate the most behaviors and hopefully more than the table topics control, which is essentially our placebo. And we were looking at outcomes of advanced directives and other behaviors like conversations and whatnot. So for randomization, we had 5 strata. So we were looking for communities that were Black, urban and rural, low-income white, urban and rural, and then Hispanic. And our goal was to recruit 75 sites with 20 to 50 participants per site. You can see here we had a great social media page. Our partners at Hospice Foundation of America, Denise Grant was our marketing person. She made these really great social media posts. These are, I remember we were really excited about these. These seemed like so long ago. But when we crossed over to 50 out of 75 was a pretty exciting time. We had recruited over 1,000 participants about halfway through our study, which was great. And so that's how we got all of our hosts. Man, this thing is not happy with me today. And this is actually, thank you to Heather Costigan for getting me this updated map. This is as of yesterday. We have over recruited. We've recruited 78 hosts in 31 states across the US. The green dots are events that we have already completed. The orange ones are scheduled and ready to go. Just waiting for the date. We hope to complete all of our events by the end of August and our 6-month follow-up calls 6 months after August. We also had received an NIH supplement to try to adapt the game for work with patients with mild cognitive impairment, and we did some events with those kinds of populations, Alzheimer's groups and whatnot, and those are the purple dots that you see there. So what's amazing to me and a testament to the team's dedication is that for every dot you see on this map, 2 of our research assistants actually flew to the location to help deliver the intervention and collect the research data. So they were living out of suitcases for basically 5 years, which was amazing. All right. My goodness. Okay. So where are we with the trial? I wish I had data. Hopefully the next time I give this talk, I'll have some. We have recruited over goal for our individuals. We, like I said, have 78 hosts right now. We do get occasional hosts that they schedule an event and, nobody shows up or they drop out at the last minute. So that's why we over recruit a little. We've only had about, I think like 2 or 3% dropout, but we have right now 78 hosts. 1,600 participants. We've already exceeded our goal of 1,500, and that's because we say we want at least 20 people at each event, but some events have 50 people show up, so that's why we're over our recruitment goals. We do follow-up interviews, qualitative interviews 2 weeks after the event in a subset of populations, so we have over 180 interviews there, and then we interview all of the hosts that get an intervention. So we've interviewed 56 of 60 so far. And this is, I think, most impressive is our 6-month interviews. We have 722 follow-up qualitative and quantitative interviews. So we will be doing a lot of qualitative analysis, a lot of coding. We'll be leveraging AI for some of this, and you can see the breakdown of our various sites. We were really successful getting urban Black sites. Our least successful was rural Black, and urban, low-income urban white was the most difficult. Get what you get. So uh, it's been very, very successful. So that's the Project Talk trial. We don't have quantitative outcomes data yet, but what I can tell you is that from the qualitative interviews that we've reviewed and just anecdotally from our interviewers is that both the Conversation Project and the Hello Game have extremely positive feedback and they were high impact events. People really found them meaningful. There's high rates of behaviors. Of course, we haven't looked at the quantitative data yet. Everybody's still blinded. But we have started to look at some of the qualitative data and think about our model from an implementation science perspective. And that is where Dr. Erica Van Dyke's Dr. PH dissertation, she recently got her Dr. PH, and her dissertation focused on really looking at our host interviews and our host experiences and mapping those onto an implementation science framework, which I'll share a little bit about. So for those of you that may not know about implementation science is really the process where we try to get our research from bench to bedside to population. And unfortunately, only 14% of research that we do that has interventions that have an evidence base actually translates into a practical bedside application. And so the goal of implementation science is to increase this number and make sure that the things we do these trials in actually make it to the bedside so that patients are actually using it. And that we can do it hopefully a little quicker than 17 years, which is the average time it takes for an intervention to make it to bedside and implemented in practice. We used for our evaluation, or for Erica's evaluation, we used the CFER framework, which some of you may be familiar with, but it essentially maps out all the various aspects of the things that get in the way of the intervention being implemented. So you can see the green box over here. This is the thing. This is the, in our case, the game or the conversation project that's being implemented. And there's all of the characteristics of that thing, you know, where it came from, what evidence does it have, why is it better than other interventions, is it adaptable, can you study it, these kinds of things. And then implementation processes, things like teaming, assessing needs, planning, tailoring strategies, engaging people in the research and the intervention. And then there's also the setting in which the intervention occurs. So you have the people here in the middle, right, that are the ones that are either doing the intervention or helping to deploy the intervention. But you have all of these things that can get in the way of interventions getting into practice. So structural characteristics of the environment, maybe it's hospital bureaucracy or relational connections, communication, culture, tension for change. And then you also have a bunch of factors in the outer setting, things like policies and laws and finances, and other types of determinants that help determine whether or not a strategy gets implemented into practice. So we use this framework to evaluate our model using our community-based delivery model to try to understand why we were so successful and like figure out what our lessons learned from that was. Ugh, this. Okay. And so what Dr. Van Dyke's intervention or analysis showed was that the intervention had a lot of, well, I should say, she did interviews for each of those domains. So she looked at the innovation itself and asked the hosts questions about the intervention and how complex was it? Was it adaptable? And why did they choose, or why did they think that, you know, the intervention that they got was better than other things they've done in the past, and an assessment of their costs. But then also she looked at the inner settings, so the networks and the communications, and how did the hosts recruit for these events, and who did they work with, and what were the roles of the people that they were working with, and what was the culture like in their various communities to pull off these events. All right. And so from all of the interviews, I'm just going to kind of cut to the chase. This is sort of the conceptual model that we built that showed why the community delivery model was so successful. And we mapped it onto the CFER. So you can see here, this is the community, right? Orange is the innovation. This is the intervention being delivered to the people in their inner setting. So we went into their local community, that's this teal circle here, and we delivered the two different interventions. And the thing that really transcended the inner setting in this blue outer setting, which the outer setting, remember, is the, you know, policies and laws and finances and infrastructure and institutions, all of the things that sort of help to deliver, is that the hosts were really the central conduit here. They were at the center of the model, that without the hosts, we really weren't going to, the hosts were reporting that the reason that they were able to do all of their recruitment is because they had really strong community connections. And what we do from our research assistance is that we were able to successfully get into the community because of this conduit. And the hosts were telling us in the interviews that they really were pulling resources from our infrastructure and pushing them into the inner setting or the community setting, and that they were doing that having our infrastructure just helped them to do something they already wanted to do. And that was a really key part, this sort of push and pull of resources from the outer setting, us, into the inner setting, the community. And we were very flexible, or as flexible as possible during the trial, to try to make sure that we had cultural adaptations. You know, we translated things into Spanish. We had to make tweaks along the way. And we recently just published a paper actually about our experience in Spanish Hispanic communities. So when Dr. Van Dyke went into depth with the hosts to understand why and how they were so successful recruiting, what she learned was that they all used different strategies and various complexities, and that the more different lines into the community that they had, the more different ways that they tried to recruit for these events, the more successful they were. So the more complex and multiple engagement strategies, the better their recruitment was. And similarly, they had a lot of communication channels that they would say, I could never have pulled it off without, so and so, this organization or that organization or the pastor or whoever it was. So these relational connections were super important. And then when we looked at differences in Spanish sites versus non-Spanish speaking sites, we learned that the Spanish communities were much more intentional and honed in on ethnicity and culture, and the fact they were in underrepresented communities, and the hosts were really motivated by altruism around that specific culture and community. So that's not to say that the Black communities didn't have those themes in there as well, but the Spanish ones, the Spanish hosts were really saying things like, this is so important for Hispanic people to learn about. And that was a central driver of their success and their motivation for getting these things pulled off. And then the last piece, when we look at the outer setting, what Dr. Van Dyke learned was that even though this was a lot, right? We had them do all of our recruitment, they marketed, they ran these events, they arranged the food, they did all the logistics, but because it was aligned with their organizational mission, they thought it was worthwhile. So no one really was saying like, oh, it wasn't worth it. They were saying it was a lot of work, it was time intense. The $300 you guys gave us like barely scratched the surface of what it quote cost. But because it was aligned with our organizational mission, it was a successful event. It was rewarding for them. And that without our host training portal, that's the pull of the resources, that was really critical for them to be successful. So they were happy to spend their time doing the logistics because we were sort of hand feeding them the information from the portal. All right. So that is sort of where we're at with the Project Talk trial. We do have Project Talk 2 hopefully coming soon. We are scored but not funded. So we have some work to do in looking at how to sustain this. If Penn State and HFA were to step away and we weren't to have research assistants going to every site, which obviously is not sustainable, how do we move this into a lower touch intervention? How do we get this to continue when our funding ends and we back away? And that's what Project Talk 2 is going to be all about. So I sort of have been mentioning the team along the way, but I just want to show my gratitude to everyone on this slide. Our partners at HFA are here on the right, led by Amy Tucci. Our program manager is Heather Costigan. Our amazing data analyst and statistician, Emily Wasserman. Erica, I need to update this slide. She's now a co-investigator on this trial, and the rest of our staff that you can see here and our co-investigators, Doctors Levi, Green, Hollenbeek, Gordon at University of Kentucky, and Dr. Murphy. Everyone has just been amazing on this project, and it's been really, really fun and rewarding to sort of see this 10-year sort of timeline come to fruition, and we're close to having results. So with that, I will stop and take any questions that you may have.
If anyone has any questions, feel free to unmute or put it into the chat. Dr. Van Scoy, I hope you'll come back and present once you have your results and
Yes,
let us know
for sure.
how things worked out for you.
Oh, for sure. When we have results, you won't be able to shut me up.
If nobody has any questions, or if you think of something later, feel free to reach out, and I'm sure Dr. Van Scoy would be happy to answer your questions for you.
All right. Well, thank you everyone for coming. It's always good to see some familiar names and some new names, and I'm always happy to talk about death and dying whenever. All right.
So with that, we'll let everybody go. If you want to hang out and ask some questions, we'll stay on for another minute or two, but if not, enjoy your afternoon. Thanks for coming.